All right. Well, sorry.
Don't change anything.
All right. Hey, everyone. Dr. Jayram from Nashville, director of our bladder cancer program. John, I can't see the slides that you're putting up. So can you go to the patient selection um, slide that I had?
Yeah, go ahead. I'm there.
Uh, okay. So the question that comes up with this is, okay, hold on one second. I got to find the slides that I had print. But the question that comes up is how do you know who to send this to? And I will tell you this, the AUA guidelines is a little bit they're important to understand when you think about who to use a urinary biomarker on. So, the initial evaluation of low risk microhematuria, there's not a whole lot of benefit by utilizing a urinary biomarker because the risk of having urothelial cancer is so low. Um, so I would tell you that the selection criteria for who to use this on is basically any patient you would order a regular cytology on. So the thing I like the most about the marker is a compound result where you get a regular cytology and the URO17 back. And it allows you to kind of understand what both markers are. A lot of people poo-poo cytology, and understandably, there's a lot of reasons why. But as a bladder cancer guy, cytology can still be an important marker. If cytology is positive, you generally know something is going on. The problem is there's so much other results that you get, atypicals, indeterminates, suspicious, that it's hard to understand really where to go. And then the other big problem with cytology, it doesn't pick up low-grade disease. So in a nutshell, here's who I perform the test on: patients who are low-risk microhematuria patients that are generally persistent in their microhematuria. So the initial workup on these patients is generally nothing. Follow them closely, maybe get an ultrasound. But if these patients come back, that's where I get this test. Or if these patients are borderline, so patients who maybe are smokers, they're a little bit older, they really don't want any invasive testing done, this is a good test. Again, like John mentioned, the NPV on this is extremely high. So if these patients have negative URO17, they have 0 cells seen, I generally take it very, very concrete that they don't have any risk of having urothelial carcinoma. So those are the guideline-based microhematuria patients who have persistent microhematuria. And then the gross hematuria patients, to me, the important thing is these patients are all going to get scoped regardless. So some people say, well, what does it matter what the cytology shows? Well, if they have a high-risk URO17, you can change the site of where you do the cystoscopy, the anesthetic requirement, and you can generally change your approach, and we'll go through a case or two that shows that. And then the trickiest group of patients for urinary biomarkers, and this has been the case for a long time, are those who have had bladder cancer and had intravesical therapy. You get a lot of junk with any biomarker in this space because of the previous treatments, the previous inflammation from BCG, et cetera. And so you're going to get some noise here. And in my experience, this marker, just like the others, you'll get some false positives. But I think the important thing is if it's negative, it isn't really important because, again, you really don't see the presence of cancer with a negative URO17. And then you can try to monitor the quantitative result over time to see, how to triage patients. And we'll get into that in a little bit. So I utilize a bladder wash. And if you're just doing a white light office cystoscopy, I'll get a barbitage specimen to send, which to me is a higher yield than traditional cytology. So changing slides to my clinical workflow, in patients who are high positive and they have hematuria, I usually go to the OR and I do a cysto under anesthesia that will allow me to biopsy them because, again, in my experience, these patients usually have papillary disease or they usually have something that's worth biopsying as opposed to just someone who I just want to see, maybe we'll find something, maybe we won't. These patients, we usually find something. And then the opposite is also true in patients with gross hematuria who have a negative result, so they don't have anything. Then I usually de-escalate their care to doing an office cysto because it's generally unlikely that I'm going to see something malignant. And then in patients who have a history of bladder cancer, negative results or low positive results tend to be able to prolong surveillance periods. So patients who's been on BCG or have had CIS in the past, maybe they've had a negative URO17. I'm not that worried about increasing their frequency of surveillance. We talked about low-risk microhematuria patients. I think that's a big value add, especially in today's era where we're really starting to de-emphasize full workups for those patients. This is a nice thing to do, to be able to say, okay, we've done this test. It doesn't really show much. I'm not worried about you having cancer. There may be some other things that could be going on, but we really don't need to stress out about having bladder cancer. Like I had mentioned, the concurrent cytology reporting is important. In patients that have a positive URO17 but have a negative cytology, the first thing that comes to my mind is that they have low risk or low grade disease. So that's important, right? We have a lot of options these days for low grade disease. We have perioperative chemotherapy. There's a lot that maybe goes into planning there. In my site, we have to order perioperative chemotherapy before we do a TURBT. And so if I have that result, I may go ahead and order that. With the suspicion that that patient will benefit maximally from putting in intravesical chemotherapy, because again, those are the patients who do. And then combining the marker with blue light or NBI or some sort of enhanced cystoscopic imaging, to me, is kind of the best way to triage or really do point of service testing for these patients, because you can get a fairly quick understanding of what's in their bladder. So if someone has a negative URO17 and then their blue light is completely negative, I feel very, very confident that we're not missing anything. And on the same hand, if someone has a high risk URO17 and we see something on blue light cystoscopy, and I'm sure a lot of you are familiar with blue light cystoscopy, but you can get avidity in the bladder for various reasons of inflammation, erythema, prior treatments. But if their URO17 is high positive and we see that, I'm more likely to do a biopsy because I'm more likely to be concerned about it. So just a couple cases that we've had over the years that I think have been somewhat informative about how the marker can be utilized. A 93-year-old male that's referred to me for bladder wall thickening on a CT scan. I think we've all seen something like this. The patient's elderly. You really don't want to do too much. The cytology was atypical, but the URO17 showed high positivity. So we elected to do a cystoscopy with biopsy in the OR, as opposed to putting them through an initial screening procedure with an office cystoscopy. And we found meaningful disease in this patient that needed to be treated. So again, if you just get the atypical back on the cytology, maybe you do an office procedure first, and then you end up, switching to an OR procedure. But in this case, we went straight to the OR. A 59-year-old female with microhematuria that's had 3 positive episodes of this. Her GYN or her PCP has referred her over because they thought it's, maybe a little bit more than they should see, but they've been treating her for a UTI or cystitis. So the cytology is negative and the URO17 is high positive. And I've seen this a couple times where, again, what we talked about before is that my clinical suspicion now is that maybe this patient has low-grade bladder cancer. As we know, traditional cytology usually doesn't show anything on that, but if you will find a mark or a signal on URO17. So I kind of went into the procedure thinking she had low-grade disease, and I found that, and I had ordered mitomycin prior to that, and we put it in her bladder, and I think that was a good use of that. So I think that you can start to make some connections based on what the cytology is and what the URO17 is. In a similar way, if the cytology is positive and the URO17 is positive, which it usually is, you can pretty much assume that they have high-grade disease somewhere in their bladder. So
well, Jayram, I could just jump in. So, like for example, on if you see a urine cytology negative case, without URO17, because of cytology's low sensitivity, you can't have a tremendous amount of confidence, in that patient being disease-free. But if you have utilizing URO17's NPV of 95% to confirm that negative cytology result, you've indicated in the past that gives you confidence in that cytology result, and you can go with that, right?
Yeah, I mean, I think it's still important to realize that yes, cytology has a poor specificity, but mainly it's because it doesn't pick up low-grade disease. So this is still something that I think is evolving. We're getting more information as we go on a lot of the newer markers. What I like about this is, again, that dual reporting, so that you can right away say, because again, to your point, cytology by itself is just not a great marker anymore, because there's just a lot of open-endedness with, okay, number one, you don't get granular yes/no information. You get a lot of this other stuff. But even if you do get a no, you can't be positive that you're not dealing with low-grade disease. And low-grade disease now is becoming more important because we have options to treat it. There's a lot of new clinical trials in the intermediate risk space, number one. Number two, we're finding out that there are a subsect of a segment of low-grade patients who can have some risk factors to progress to high-grade disease. So it's an important group of patients to capture. And so, to me, a big benefit is it'll pick those patients up. So an 88-year-old male, bladder thickening, microhematuria, multiple medical issues, immunocompromised. Again, patients that we see very commonly. These are difficult patients because, do you put them through an endoscopic procedure right away? Do you kind of wait on it? Do you see what to do? I think getting a marker here could be important. And in this case, it was an indeterminate cytology, but a negative URO17. This was an interesting case. This was a couple years ago. I remember this very well. I said, I think we can wait. I don't think we need to do anything. I feel pretty good that the biomarker has helped us here. The patient saw another urologist due to a somewhat pushy family member, and they performed cystoscopy, which again, I don't think is the wrong thing to do, but it didn't show anything, and then the patient was hospitalized for 4 days with a multi-drug resistant UTI from the procedure. So we all have these patients, and there's no perfect way to deal with it, but I think if the more information we can get pre-invasive testing, the more we're likely to make the right decision. 76-year-old male with gross hematuria, atypical cytology. So this patient was sent to me by a partner who had just had atypical cytology and I think had multiple atypical cytologies. Cystoscopy and a CT was unremarkable. And then repeat gross hematuria 3 months later, and then I checked a URO17, which was high positive. The cytology was still atypical. And so I got a repeat CT scan, and then was planning on doing retrogrades and a more thorough workup looking at the upper tracts. And now we see a lower pole mass in the left kidney, and ureteroscopy confirmed a 3-centimeter low-grade urothelial lesion. So presumably they had this, prior, but just wasn't able to be seen on the CT. Maybe it was smaller, but again, the marker shows us that there's something going on. So. The next slide, 86-year-old male with a history of microhematuria and lower urinary tract symptoms, had bladder cancer 5 years ago with BCG 3 years ago. So again, somewhat common. These patients are, can be helter-skelter with their surveillance in terms of showing up. Someone who's 5 years out in this age range, we usually don't do that much surveillance, maybe a cysto every year. But this patient now has microhematuria and has a negative CT. The cytology is again atypical. The URO17 is high positive. So 86, I don't want to condemn this person to general anesthesia just yet. So I did a blue light in the office, which showed a patch of avidity on the left lateral wall. So again, in this group of patients, even blue lights are tough to interpret, right? Because there's going to be some noise on the blue light from all the previous treatments. But with a high positive URO17 and then again some avidity on the blue light, I think it's more likely that this is something. And I biopsied this kind of in that setting, and it showed CIS, which changed how we managed that patient. And then the last case I have, and these are all these are all cases that I have. So this isn't anything else except just me having kind of this crazy bladder cancer practice where I see a lot of interesting things. But a 6-year-old male, status post-nephroureterectomy for high-grade UTUC. As we all know, we have to monitor these patients with lower tract endoscopy and occasional upper tract surveillance. So he's adamant about minimizing cysto. This patient was coming from 2 hours away, did not want me to scope him, as frequently as I had wanted to, which is usually every 4 to 6 months for the first couple of years. And so I said, okay, well, we'll monitor you with your cytologies and URO17s, and these have been negative for 3 years now. And he lets me, scope them once a year, and I haven't seen anything. So again, makes me feel more confident that we're not missing anything. If patients don't want invasive testing, which a lot of patients don't, I think this can help. Again, I think that's an important thing. The biomarker is never going to replace invasive cystoscopy. I think that's where some people get maybe a little bit confused, in my opinion, about utilizing the marker, because I still get people, who I work with, even my own practice, who we use the marker, and maybe it doesn't change things dramatically. Again, this is just one more piece of the puzzle. This isn't meant to replace clinical decision making. It's not meant to replace what you think as the doctor, but we're just looking to get as much information as we can. And honestly, it's not that much different than what's happening in prostate with some of the genomic testing. You're not making that decision on how to treat that patient fully based on those markers. You're using it as part of your algorithm, and just one more piece of the puzzle to help you make a good decision. So my last slide is kind of a clinical summary slide, kind of a lessons learned slide on this. Is that, I like that there's a lot of activity in this space, in the biomarker space. To me, there's kind of two types of markers. There's the cytopathology marker, which is what this is, and then there's the next generation sequencing marker. Both of them have some value. I think a test like this is important because it's generally cheaper. As John said, you have some pathology in-house business opportunities with it. The result usually comes back faster, and I think in this case you can combine it with cytology or with FISH, if you use FISH, to try to make a better decision on how to treat patients. And so it detects low-grade cancers and smaller lesions. I think the negative result is really, really powerful. It is exceptionally rare to get a negative result and then have active cancer in the bladder. Concomitant reporting of cytology, again, gives you that kind of double result, which to me, you can really make some inferences on in terms of what's going on. And then I think the last point's important. False positives do happen. I've used a lot of biomarkers and tried a lot of things. Nothing is perfect, and that's why we don't have a lot more options in this space. And like I had mentioned before, it's really incorporating this as one part of the overall the puzzle. I utilize existing guidelines, look at risk factors, their age, smoking status, imaging. All of these things kind of are put together, but I found that this has been a helpful thing for me in a busy bladder cancer practice, and really also in a triage kind of practice for patients who have gross hematuria or who have persistent microhematuria, to try to figure out the best way forward. So, the last thing is even though you have false positives, bladder cancer is a dangerous disease. And so over-evaluating patients is definitely better if you want to make the mistake of one or the other than under-evaluating patients. And so the goal is let's do less invasive testing. Let's just do it smarter. Let's do it in a more appropriate group of patients. And I think markers like this are helpful to accomplish that.
Great. Well, that's great, Dr. Jayram. Thank you for that invaluable feedback. And you've been using it for several years now, and that's the feedback that we're hoping to share with the community. So thanks very much for that.